everyone. Nice that you're here. I'm honored to give the lecture of Professor Sluijter. Sluijter was my tutor, and I was trained by him in 1985 already, and I continuously had contact with him about cultural frequency and other aspects. So what he did, he was the godfather of cultural frequency, the inventor. He invented STP, Sluijter Poisson, the irregular burst type of cultural frequency. And he was continuously thinking about what is the mechanism, how does cultural frequency work. So this was the lecture he held in Madrid, I will tell you about his lecture, and I gave some explanations about the backgrounds. So yesterday we saw already what pulse radio frequency is, so I will skip this slide. But how did we come to the idea? If we look at facet pain, nociceptive pain, you see here, this is the pain focus, and the conduction fiber is here, and we did a block at this level. So that was the pulse radio frequency, the blocking of the conduction. But if we look at a hernia at L5+1, we did the treatment peripheral from the conduction, and still it worked. So there must be more. Here you see that, there's the hernia, we performed the DRG blockade there, and still it had a good effect. So how can you apply radio frequency without heat, without pulsing? So what are the parameters? I told you yesterday already that the parameters have changed. We started with frequency 220 milliseconds, under 42 centigrade. Frequency since 2009, 5.5, and since 2015, we do the irregular burst type, the Sluijter Poisson. So here you see why we changed it. Yesterday I told you there are heat spikes when you do 220, and Cosmo showed this. We look at it as duty cycle. When you use 220, the duty cycle is 40. When you do 5.5, the duty cycle is 25. With STP, the duty cycle is about 15. And you see here the slide, the profile of STP, a burst type irregular pulse radio frequency. And I want to emphasize the temperature. The temperature is only a side effect. That's a myth. So there are some generators which say go to 42 centigrade. But then sometimes the voltage has to go to 100 volts. And that's dangerous because then you get electroporation and tissue damage. So the temperature is a side effect. Don't go to 42. That's not needed. It's the parameters of the electric field that are important. Temperature is a side effect. We can apply pulse radio frequency as an invasive therapy, or nowadays also as transcutaneous. And this is the new generator with 4 STP channels. So, about irregular rhythms accentuate biological effects. So if you have a regular pulse, the body can say, oh, that's not so dangerous. But if it's irregular, there are more biological effects, and these are the studies which prove this. And this is also now used in spinal cord stimulation and in TENS. Irregular rhythms are more effective. If we look at the literature and all the case reports on RCTs, all these techniques have been applied with relatively good results. And these are the generators which are available, which I use. I told you yesterday that also the strength of the electric field with pulse radio frequency is 4 times higher than its heat. And in Sluijter and Texera, they published about intravenous pulse radio frequency. And they had some remarkable results. The article, I have not the slide of it, but you can read it. And that they then in Nijmegen University, Rampoesland did a finite element computer analysis of the strength of the electric field with intravenous pulse wave, and she saw that it was 200 volts per meter. So 200 volts per meter is very important. That's the figure, 200 volts per meter. It's about 5 centimeters around the tip of the shaft of the needle. There is the effect in the tissue. So it has not to be very close to the tissue, even 5 centimeters around the tip. There's an active field which influences the cells. This is important thing to know, and the cells communicate with an electric field of 50 to 250 volts per meter. So this is the lecture. The agenda is introduction, pathophysiology, mode of action, application, persisting nociceptive pain, and other indications. Who are important giants in electrotherapy? It was Jacques Arsène Barcelona. He published about the effect of electricity on biological systems. Then we have Albert Giorgi, and he published about the Krebs cycle, the role of free radicals in illness and redoxing cycle, and in Brazil, Brazil, he did work on the PRF mechanism, and he showed that its effect is the recombination of radical pairs. If you look at the cell, when Sluijter went to the cell biology, because in the cell, that's what is important. And an eukaryotic cell means that the cell has a nucleus. We know all about the components which are in the cell, and a healthy cell has an aerobic metabolism. But a normal functional cell needs free radicals for an aerobic metabolism. In the case of overproduction of free radicals in an illness, the cell tries to survive but loses its function by going over to an anaerobic metabolism. And in blood you can measure the anaerobic metabolism products, the lipoperoxidase. And you could use T-bars as a marker of oxidative stress. That's what Josino Brazil did in his study, and he showed that pulse radicals works. It has a healthy effect on these cells. In fact, oxygen, we need oxygen, but oxygen is in fact a poison, which is capable to kill us in about 80 years. So the counter-argument against oxygen is that the transfers of electrons is the basis of aerobic life. So we need oxygen, we need radicals for the cell to have an aerobic metabolism. Transfers implies the presence of radicals. Radicals play a crucial role in intracellular signaling, and additionally, nature could not foresee old age. What is the pathophysiology of cell stress? Oxidative cell stress. Then comes the sterile inflammation. Stress and stress response are very important in this and the autonomic nervous system. What happens if the cell gets oxidative stress, is attacked by free radicals? You see that in this tomate, the cell dies, and the tomate is damaged. So the free radicals are reactive oxygen species and reactive nitrogen species. And in the cell stress, there are several forms of cell stress: oxidative cell stress, toxic cell stress, and prosthetic tubular cell stress. What happens? First you get oxidative stress, and then you get sterile inflammation. You see that here. Inflammation is first oxidative stress. There's a mitochondrial hyperfunction, shortage of energy, signal system. Then you get exponential production of oxidative radicals, the control transfer to the epigenome, energy saving, functional loss of the cell, the factor NF-kappa bank, then the documentation of the epigenome. I will tell you more about this. What are the working mechanisms of PRF? First, the stunning, which may last 2 days. Then the clinical improvement, which lasts about 3 weeks. I may continue about 1 year. And the mechanisms I told you last lecture, yesterday, could be in neuromodulation. Dusit has written about the observation about pulsating in joints, by Teixeira. It has proven to be immune-inducing. Several studies in rats, which I told you yesterday, and PRF fields on monocytes, and reduction of oxidative stress. That's explanation of the study phenomenon. So we use in the clinic already 25 years these procedures, and you see stunning effects after DRG, intra-articular treatments, sacral pulse trap, peripheral nerve treatments, lasting up to days, and after 3 weeks you see the longer lasting effect. And the mechanism is now the hypothesis that it works by recombination of radical pairs. It works anti-inflammatory by recombination of radical pairs. Here you see the slides of Professor Brazil, which shows it. So normally we all have in our body the antioxidant defense mechanisms, that is superoxide dismutase and also catalase and glutathione. This is the study of Professor Brazil, we showed yesterday already. So Rohof was able to reverse muscular oxidative stress and changes in the antioxidant defense induced by trauma and biological systems we have all in our bodies, our superoxide SMB and catalase and glutathione peroxidase. So what are the differences between thermal and Rohof? I showed you yesterday. Rohof works anti-inflammatory by oxidation, and the indication is oxidative stress. It works anti-inflammatory by recombination of radical pairs, antagonizes cell stress, and gives improvement of the illness. And it's quite different from nociceptive clinics thermal levels. So, further explanation. If we have to look at the genetics. Well, do you know what epigenetic is? Epigenetic is a profession studying if a gen is put on or off by different chemical groups coupled to the DNA. And chromatin is a complex of DNA proteins in the nucleus of the eukaryotic cells, and that means it consists of nucleosomes consisting of 8 histones surrounded by the DNA chains. So that's the basic. And epigenetic changes, what is changing then? By methylation or demethylation and post-translational histone modifications and encoded microRNAs. And epigenetic changes may protect the cell because it knows how to deal with a specific form of stress. And that's known to persevere, sometimes even in a response, even if the factors causing the response have changed, even for 2 or 3 generations. So if the epigenome is changed, the body knows it, and it's going over from generation to generation. And this is a very important transcription factor, the nuclear factor kappa light chain of activated B cells, protein factor. What are transcription factors? They are needed when a gen is active and want to produce a protein or peptide. So it controls the transcription of DNA, cytokine production, and cell survival, plays a key role in regulating the immune response to infection. Incorrect regulation of NF-kappa beta has been linked to cancer, inflammatory and autoimmune disease, septic shock, viral infection, and improper immune development. So it's also involved in processes of synaptic plasticity and memory, so it's a very important transcription factor. And we have about 1,400 transcription factors, and each transcription factor regulates about 200 genes. What happens in a sterile inflammation? First there's stress from injury or mental stress, then you get that the eukaryotic initiation factor 2 alpha is activated, then the transcription program is activated, and you get changes in the epigenetic part. So here, what are the forms of stress? These are the forms of stress, and then you get integrated cellular stress with activation of the factor, the transcription factor, and inflammation. And the changes are in the epigenetic, in the genetic system. What about immune cell stress and PRF? The stressed immune cell tries to survive by an an anaerobic metabolism. That's good for the cell, but not for the organism, because the cell loses its function, the warning and cleaning function. Most prescribed drugs in these situations are inflammation inhibitors, causing worsening of the situation and the illness. So redox Prof misses this disadvantage. Prof works only on ill cells and not on healthy cells. That's also very important. It's not damaging. It normalizes the reactivity of the immune cells by restoring the redox status of the immune cells and restoring their functions. So it's a healthy procedure. It heals the cells in the body. It only works if the cell is not dead yet. So if you could apply pulse radiofrequency in the acute phase, then to my opinion, it has the best result. I told you already yesterday this slide about the inflammatory state that is continuously monitored. The afferent system, the visual info, musculoskeletal and emotional stress, they come together in the TNS, and then you see that here the troctus nucleus solitarius goes to the brain, and then you get the reaction in the locus coeruleus, which is sympathetic outflow. Okay, see it again. So from stress to the immune response, showed you this slide already also, and there's also a reaction of the vagal system, is the cholinergic anti-inflammatory response. What happens if people come into stress? You get immediately an inflammatory reaction, and it can be that if the immune system is capable of handling the situation, then you get the homeostasis and the inflammation is gone. But if that's not the case, then we call it allostasis. And then you get an allostatic dose. And the final outcome is the anti-inflammatory ratio of the transcription program of the epigenome. If the end result is inflammation, it leads to changes as described by Geis, that's a doctor from Germany, by exhaustion of the hypothalamus pituitary axis and persistent pain. Here you see the study of Geis. They had 12 patients with failed back surgery syndrome with hernias, and they first did the dexamethasone suppression test, and if the test was negative, so if there was an exhaustion of this axis, they could predict that all the patients developed a failed back surgery syndrome. So in chronic stress enters into the same inflammatory pathway as injury, but at a different point. It may cause also sickness syndrome. This is where meaningful adaptation ends. The consequences depend on the anti-inflammatory potential of the HPA axis and the cholinergic anti-inflammatory pathway. Those are the defense mechanisms. You see the slide again. I showed you already this very good article of the inflammatory reflex. I showed you also this slide about the stimulation of the cholinergic inflammatory pathway. And the sacral cluster, I showed you already yesterday, but that's a possibility because in the sacral region there's the parasympathetic innervation. If you stimulate the parasympathetic innervation, you could stimulate the cholinergic inflammatory pathway. Then what is the role of the autonomous nervous system? The autonomous is a system that allows variations in sympathetic and parasympathetic activity without major molecular changes. There's a boundary, however, on the sympathetic side. Outside this boundary, tissue must take the full brunt of stress. So additionally, semi-continuous exposure to the far sympathetic side is hazardous. Then you get overview of the maintenance, the cardiovascular risk and malignancies. If there's that reaction, then you get functional loss, molecular changes, and downregulation of the electrochemical endosynchronization and lower life expectancy. So how does pulse ref work? It works on recombination of radical pairs, preventing intracellular damage, and it resets intracellular signaling. And splitting of a cell that lasts several hours, but the recombination of the radical pairs that is happening within milliseconds. This explains the efficacy of the PRF of the ultra-short active phase. It does not concern the required duration of treatment. This must be accepted to let be known. The advantage of PRF, you can do it invasive and you can do it transcutaneous. The advantage is it can deliver adequate current densities to the obstructors. The disadvantage is that a large electric field, when you do too close to the nerve, it will be a very high electric field, then it can be damaging. Repeat treatments less desirable, and systemic intravenous PRF has been discarded. The targets are nerve conduction, targets are no longer acceptable. If you do an ERT, preferable to do it multi-level. What are redox pulse ref? Transcutaneous is redox pulse ref. The observations are immediate change in the heart rate variability. There's many publications about heart rate variability, and Professor Sluijter did several investigations about this to look what happens with the autonomic and the parasympathetic system. So it goes upward in patients with normal conditions and downwards in patients in poor conditions. There's a silent interval in 1 to 4 days, and it improves mood and condition in patients who have no oxidative stress. None of the above applies. So this is transcutaneous pulse ref. I showed you the slide yesterday, 2 RCTs, which shows that it worked on knees and shoulders. I was also a patient 4 years ago. I had a minor stroke and I had a paralysis of my left arm. And after 4 days, I had contact with Menno, and he said, I had still some paralysis. He said, you have to do the pulse ref, the general pulse ref, which means that you have an electrode of your axillary artery and one on your underarm, and you do then 20 minutes PRF, and it works then on intravascular effector immune cells. So all passing cells are being treated, and they come all over the body, of course. And after 1 hour, my paralysis was over. So, and there are several patients who had the same experience. So I was glad to have it. And the other way of doing it is the regional treatment, that you place the electrode plates over the tissue you want to treat. There are several plates with several sizes, and we are busy to investigate this. So the transcutaneous, the advantage is that it's controlled in homogenic electric fields, zero damage, so it works only on cells which are ill and not on healthy cells. It's very important. You can repeat it. And it's usable also for non-pain indications if patients the tissues are in stress. And the disadvantage is that the deep targets in the curve that has not been confirmed whether it helps them. So here is a slide from Professor Sluijter with his investigation about the heart rate variability. The RMSSD reflects the integrity of vagus nerve-mediated autonomic control of the heart. And if the score is, mean score is 59, lower score has a higher risk. So we see here the differences with oxidative stress, good condition, oxidative stress, poor condition, before and after. So there's a clear change which can measure the effect of pulse radio frequency transcutaneous in these cases. Nociceptive pain is a simple approach. Even minor trauma causes inflammation and therefore pain. in muscle, tendon, and periostal joints. In about 70% of individuals, inflammation settles down spontaneously. In the remaining 30%, the environment can be temporary and continuously inflammatory. This turns incident pain to persistent nociceptive pain. Further spread of inflammatory pain, for example, sensitization, is a downstream effect. We all know. Also, an interesting study they did on lame horses, and a horse can be very expensive, and if a horse has a lame leg, then if you can treat it effectively, that was very nice, and they had several horses which they treated with good results. Some final statement. The cause of nociceptive pain is an inflammatory event. The conduction of a nociceptive stimulus through a nerve is a downstream effect. Persisting nociceptive pain is caused by a preponderance of inflammatory cytokines and exhaustion of the hypophysis pituitary axis. The innovation is therefore a bizarre treatment. Any treatment should bear in mind that adding to sterile inflammation will be strictly avoided because it's a potential lethal condition. Since ablation and PRF commonly cannot be combined, it's either the one or the other. We hope that the terms like PRF ablation and supravoltage PRF will soon be history. The last slide. The finding of the mode of action of PRF may be a milestone for treatment by other disciplines because oxidative stress is such a common first step in many pathologies, such as major depression and some other psychiatric diseases, also stroke, COPD, glomerulonephritis, osteoarthritis, age-related macular degeneration, and several dermatological diseases. Additionally, the efficacy of PRF could be tried on diseases like Lyme and post-traumatic stress as well. Thank you for your attention.
Any ideas, any questions, any very comprehensive, very well covered? Why it's not reimbursed in the States?
No, that has a history.
Yeah, okay, we don't want history, so it's fine. Yes, please.
There's a question.
Question there.
Just sharing something which I read last month about oxidative stress and the oxidative workload to the cells as well. And the article, which I forgot the journal which I read, but it states that the overnight fasting, say you skip the meals at night, can significantly reduce the oxidative workload and oxidative stress of the cells, which helps sleep restoration as well as improving the mood of many patients. And I just feel that this concept about the oxidative stress and oxidative workload might be an area of scientific research in the future. It's interesting to hear the effect of the PRF on oxidative stress as well. Just an observation, really.
Okay, thank you.
Arun, any comment?
First of all, thank you Olav for continuing the legacy of Menno. Like most of us who do enough PRF, we know it works, but now we are understanding the science and more research is happening. That is great. I just wanted to answer the question posed by Amar, which we discussed yesterday. So, some insurance companies will fund, especially if you're on the higher tier in the UK, some don't, if you put PRF, but they will fund thermal. So the idea is when you put the coding, don't put it as thermal RF or pulsed RF, just put radio frequency lesioning. We are not lying, and they will fund. It depends. But don't put it as pulsed RF, they won't fund. Just put radio frequency lesioning.
Yeah, I like to be straightforward. I know lots of discussions about the States and Europe and what, but there's something strange. We need to know, we need to explain and to convince others.
The simple answer is insurance companies are not straight.
Unfortunately, it doesn't work in UAE because the term non-pulsed, there is pulsed and non-pulsed. So if you do another type, you have to put non-pulsed.
Simply radio frequency.
There is non-pulsed radio frequency. That's the code.
I received a reply from an insurance company to specify if it is pulsed or non-pulsed,
Yeah, that's what I said.
especially with maybe some basic insurance.
Oh yeah, okay. Okay. Perfect. So we come to our Dr. Shaban. Sorry. Yes, please.
Professor, thank you very much for the talk. I was wondering, how do you explain the long-term effects of one episode of pulse RF compared to having somebody a continuous spinal cord stimulator? We are doing a lesion for whatever time period and the temperature changes. Why does some people get long-term effect with the same lesion compared to somebody who changed? I hope the technique they are doing is correct. Thank you.
So I think it's a complicated question, a good question. It is so that you have to consider what was the cause of the inflammation. So if there's still an ongoing process causing the inflammation, then you have also to treat that. So if there's a radiculopathy going on, then you have to treat the radiculopathy too. And that can be the cause why it's different in patients. And there can be also psychosocial problems which cause inflammation. So it's a holistic need is needed for the patient. Not only one aspect, not doing one technique. You're treating a patient. So make the diagnosis complete. And then you can do one technique or dose ref or like psychology. Then you get the results.
Thank you. Perfect. So